Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing schizophrenia, a psychiatric condition that can have devastating long-term consequences for those affected. Fortunately, schizophrenia has also been the subject of intense research that has improved the prognosis for many. I'm delighted that my guest today is someone who has been at the forefront of that research for decades. Dr. John Kane is the co-director of the Institute for Behavioral Science at the Feinstein Institutes for Medical Research. He is also a professor of psychiatry and molecular medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell and the immediate past chair of the Northwell Department of Psychiatry. He's been the principal investigator on nearly 24 National Institutes of Health grants focusing on schizophrenia and related subjects, and is the author of over 850 peer-reviewed papers and has been consistently ranked in the top 1% of researchers in his field based on the citations of his work. John, welcome to Well Said.
Thanks so much, Ira.
How have you been doing during this crazy pandemic that we're still very much in the middle of?
Yeah, I'm very fortunate. I have not contracted COVID, and I have tried hard to, adhere to all the safety guidelines and so forth. But so far, I and my family have been doing well. So thank you.
Yeah, well, I'm glad to hear that. I think there's a lot of misunderstanding even around the term schizophrenia. And I suspect that many of our listeners, when they hear that word, think of split personality rather than the specific psychiatric condition. So let's start at the very beginning. Could you just define schizophrenia for us?
You're correct in that many people associate it with split personality, and that is not at all the case. So schizophrenia is a serious mental illness that interferes with a person's ability to think clearly, to manage emotions, to make decisions, and to relate to other people. And so it's a complex illness. It can be difficult to diagnose, so I'd recommend that if anyone thinks that they or a relative is suffering from signs or symptoms that might be indicative of an illness, that they really seek professional consultation. It's not a diagnosis that someone could make themselves. It should be done by a mental health professional, and it's not based on any one particular sign or symptom. What many people experience as part of this illness are things like delusions. A delusion is a fixed false belief that someone might have, for example, that other people are conspiring against them or the TV is talking to them in some way. Other symptoms are hallucinations. About 80% of people with schizophrenia will have the experience of hearing voices when no one is actually speaking. And I'm not talking about hearing your name in a crowd or something that might happen very occasionally. I'm talking about, repetitive situations where someone is hearing a voice when no one is there, and the voice might actually be trying to carry on a conversation or giving them instructions or things like that. People also experience disorganized speech, and when that happens, it means that the people around them might have a hard time understanding what they're saying. Other symptoms could include lack of motivation, lack of facial expression, lack of desire to socialize with people. So all of these things can be present to different degrees at different times, but I just want to emphasize that it's a complex diagnosis and really should be made by a mental health professional.
Thank you for laying out that spectrum. It does sound complicated, and I hope we have a chance to tease it apart a little bit later in our conversation. Before we get to that, could you give our listeners a sense of how prevalent this is and whether the pattern of occurrence is changing?
The exact prevalence is hard to measure, but the estimates range from about 0.25% to about 0.75%. So like 1 in 200 people is an estimate. It can occur at any age, but the average age of onset tends to be in the late teens to the early 20s for men and a little bit older for women. It's uncommon to be diagnosed in someone under the age of 12 or older than the age of 40. And I want to emphasize that it's possible to live well with schizophrenia, but one of the key factors we believe is getting appropriate treatment early on in the illness. That can really help in terms of increasing the likelihood that someone can recover.
I'm sort of struck by the combination of this being a very serious mental illness and the fact that you said it could occur in as many as 1 in 200 people. That seems like a lot to me. Is that number growing, or has that been stable over time?
I think it's been pretty stable. Certainly during the pandemic, I think we've seen an increase in depression and anxiety and things like that, but I'm not aware that we've seen an increase in actual schizophrenia. It is largely a genetic disorder, so it's about 70 to 80% heritable. There have been many, many genes implicated in schizophrenia, but there's no one gene that stands out, and the genetics are very, very complicated. So, when we talk about risk factors, if someone does have a first-degree relative, a primary family member who has schizophrenia, that would indicate an increased risk for that person. It's still not very, very high, but it does increase the risk. When we examine identical twins who have the same genetic makeup, they're much more likely to both have the illness if one of them does have it. So that's the kind of evidence we look at when we talk about genetic involvement.
If somebody has a first-order relative, a parent or a sibling that does have schizophrenia, how likely is it that they will have it? You're saying it's a risk factor, but it's not a slam dunk.
Not at all. No, it's still unlikely that they would have it, but it does increase the risk. Let's say you have a parent or a sibling, so maybe 6.5 or 7% risk. So when we're talking about identical twins, then it's probably more like 40% or 50%. If you have both parents with the illness, then the risk could be as high as 50%.
Yeah. Is there a male-female difference in who's afflicted?
Men tend to be afflicted earlier, but the incidence appears to be similar in men and women. It's just a question of the age at onset is a little bit younger in men.
Yeah, you mentioned something that I think is one of the things that I've always found interesting and kind of terrifying about schizophrenia, which is the age of onset, sort of late teens, early 20s, kind of young adulthood seems to be the prime period of risk for the development of this illness. Is it understood why that's the case?
We believe that schizophrenia is largely a neurodevelopmental disorder, so there are problems in the way the brain develops, and the brain is obviously very complicated, and there are what we call neural networks. There are regions of the brain that communicate with each other, and we believe there are some problems in the way those neural networks are formed. And the brain is still developing even in the late teen years. So that's probably why we're seeing the onset at that stage of life. I should also point out that there may be signs of schizophrenia that occur even earlier, but are not easily detected. And by that I mean that cognitive dysfunction, so problems in the way people process information, can occur long before the actual psychotic signs and symptoms. So we've done studies suggesting that even in childhood, there may be cognitive problems that are not dramatic enough for anyone to recognize them. But when you look at group data, we can see that there are some challenges that young people who are destined to go on to develop schizophrenia may have some challenges with cognition early in life.
I know you said this is related or thought to be related to development of neural connections, but could you speak to a little bit more about to what extent we really understand the underlying biology of that? What's going wrong there?
It's really hard for us to really explain, and I think part of it is that there's probably an interaction between genes and the environment. So things like malnutrition, complications during pregnancy and childbirth can also play a role when combined with genetic risk factors. It's not any one thing. It could, very well be the interaction between some underlying vulnerability and then some environmental experiences. And another concern that we have is that for some young people, smoking excessive amounts of cannabis may also be a risk factor. And so, as we see increasing legalization of cannabis, we think that there are some people who, particularly young people, who need to be careful based on their personal vulnerability or personal reaction.
Do you think that that's an effect only in people who have a particular genetic vulnerability to this, or is that a broader risk?
It's tricky to assess risk. I mean, I think everyone differs in their response to these substances, and I'm not saying that they're dangerous for the population at large. I just think people need to understand their own personal reaction. I think heavy use of anything, whether alcohol or cannabis, is not desirable. So one has to, be careful about moderating and understand what reaction these things are having on a given individual.
Yeah. I also want to pick up on something you said a minute or two ago about, I guess these are retrospective studies that look at people with a diagnosis of schizophrenia and then say, oh, well, if you look back, there was something that may have been an early sign of this. At least that's how I interpret what you were saying before. Is there any work being done to look at that prospectively? And is there a screening test or some sort of reliable clue in younger children that they're destined to go on to this?
Unfortunately not. That's clearly something that people are very interested in trying to develop. I think someday, if we have a better understanding of the genetics, it might be possible to do a genetic test and identify people at specific risk. But right now, we don't have any good predictors. And it can be very difficult to diagnose schizophrenia in the teenage years because sometimes the first signs can include, a change of friends or a drop in grades in school or problems in sleep or irritability. And a lot of that we see in adolescence in general.
I was going to say, you just described like every teenager I've ever known.
That's right. So other factors, can include things like isolating oneself and withdrawing from other people. But then when we start seeing things like an increase in unusual thoughts and suspiciousness, that we sometimes can identify as a prodromal period. And if someone experiences a decline in social functioning or school performance or things like that, it's good to question, what is going on? And I think if someone is concerned about that, there's certainly in my opinion, no harm in getting a consultation from a professional to see if, is there something happening. Mental illnesses are very common. We're obviously talking about schizophrenia, but, many young people develop depression or anxiety and things like that. And it's really a shame when those illnesses go untreated, as they often do, because people they're not sure what it is, they're not sure how to get help, or they're afraid of this, it might be stigmatized in some way. But, most mental illnesses we can treat pretty well. And I think it really behooves people to get a consultation if they have any concerns.
So that goes back to what you were saying before about making a diagnosis of schizophrenia. I take it that there are no specific tests of the sort that our listeners might be familiar with. There's no blood test, there's no X-ray examination, right? This is a clinical assessment.
Exactly. I keep emphasizing it does have to be done by a professional, and it requires putting together information from different sources. And it's not just, I had a bad day where I felt, suspicious because, I thought my friends had not invited me to a party or something. It's not like that. It's something that's really persistent, that's going on for days or weeks or months, not just very, very occasionally. And then it's also associated with changes in functioning. The clinical team needs to put together all of this information and make a diagnosis. Even if it's a tentative diagnosis, they might work with the person over time to see whether they can come up with an accurate diagnosis. And some people develop bipolar disorder, which involves changes in mood. Can be quite extreme. And the key thing is just trying to identify these things early, getting help, getting appropriate treatment. And the sooner we can treat these illnesses, the better the prognosis.
Yeah, so talk to me a little bit about the prognosis, because this is obviously a pretty scary diagnosis for the individual involved, if it's a young person, for the parents. What can you say to somebody in terms of their likelihood of either recovery or being able to lead a normal life with a new diagnosis of schizophrenia?
People do recover. Obviously want to help them achieve recovery, and that's why I keep emphasizing, early intervention. It's very hard to predict. Some people have a good recovery and some people don't. And so Unfortunately, we don't have good biomarkers or measures to really predict how someone is going to do. So the main thing is getting the right treatment. Some patients do very well and some patients really struggle.
Could you describe the sort of mainstay of treatment for us?
We believe that it's really a combination of different modalities. Medication can be very, very important. One of the theories about schizophrenia is that it involves changes in a neurochemical that we call dopamine, and changes in the way that neurochemical is functioning in the brain. We have medicines that can help to regulate the abnormality in that particular neurochemical. The medications can work quite well in reducing things like hallucinations and fixed false beliefs and agitation and anxiety and things like that. The medications can also really help to prevent these symptoms from coming back again. Many people describe schizophrenia as often a chronic relapsing illness. Everybody relapses, but many people do. So the medications can be very helpful in also reducing the risk of relapse. But the medicine should also be combined with psychosocial treatments, and by that we mean talking therapy, that having a counselor or a therapist to work individually with the patient, I think is very important. Having people to also work with the family. The families can be obviously very anxious, uncertain what to do. It's very important that they get counseling and what we call psychoeducation. The other domain is to have someone help the individual with work or school. And we call that supported employment or supported education, having a specialist who can sit with the individual and talk about their goals and what they want to achieve and help them to try to achieve those goals. So it's a multimodal approach that we think is most appropriate. We call it coordinated specialty care. And that just means having people from different disciplines working as a team with the patient and the family to try to, facilitate recovery.
I mean, it sounds like a kind of wraparound approach, which sounds great, but I wonder to what extent that's really accessible to many people with this illness.
It is more and more accessible. I mean, that's been a big area of research for us, and the federal government has now invested a lot of money in trying to establish programs across the United States that can provide these kinds of services to people when they need them. And so about 10 years ago, there were only maybe 20 programs across the country that were trained to deliver this model of care. Now there are well over 200. So it's something that's expanding, and we're very pleased to see that. There are a number of federal agencies that are involved. Congress has provided money. I should say it's never enough. It's a very big step in the right direction.
Yeah, that's very interesting. I also wanted to spend a couple of minutes talking about some work that I've found particularly fascinating. I know some of your work is centered on the use of new technology to monitor patients and allow them to get care in a more timely fashion, or at least have their caregivers get advanced warning that they may be deteriorating. Could you speak to that a little bit?
One of the techniques that we started using about almost 20 years ago was telemedicine. And ironically, during the pandemic, that's now become sort of the state of the art. The goal there was to provide better access because there are many parts of the United States where there are really not a lot of mental health professionals, not a lot of psychiatrists. So if we can connect with people even at a distance using telemedicine, we can provide some of the treatments that we've been talking about. The other things are using the modern technology of the smartphone. Many of us and many people with mental illnesses have smartphones. They're with them all the time. If the patient is willing to work with us, we can use that smartphone to help the patient monitor his or her behavior, their sleep patterns, their activity levels, even their social interactions. By doing that, we can sometimes get an early warning sign when someone is beginning to experience a relapse. So, for example, if a patient is having trouble sleeping, so we see with their smartphone that there's been a change in their sleep pattern, and we can contact them and see what's going on, because a significant change in sleep is often an early sign of, could be psychosis, it could be depression, it could be mania, there could be a number of things going on. But that's just one example. So similarly, if someone hasn't left their home, and I'm not talking about the pandemic now, but under ordinary circumstances, if someone hasn't left their home in a week, and that's unusual for them, we can tell that by monitoring their smartphone. or, for example, they haven't had any interaction with any of their friends who they're usually calling or texting, we can recognize that something's changed. And that gives us an opportunity to reach out to the person. One of the sad things about many mental illnesses is that when people experience a recurrence of the symptoms, they don't always call their doctor. Sometimes they're too upset or too depressed or to do that. And that's a real shame, because that's when we need them to call us. If we have a way to identify that something is happening that's concerning without relying on them calling us, that's very helpful.
That's fascinating. I can't let the opportunity pass without asking you about a recent article that was in the lay press about a completely different approach to people with schizophrenia, and specifically about people who are hallucinating, hearing voices. I'm not going to do the article justice, but it talked about a network of sort of peer-led therapeutic groups that preach a philosophy of kind of accepting the voice or voices and not treating that as something pathological that needs to be kind of treated or eradicated. Could you speak to that?
It's a complicated area, because there may be people who hear voices who do not necessarily have schizophrenia. And I emphasized earlier that schizophrenia is a complex diagnosis. We need to put together a lot of different information. At the same time, hallucinations can be a symptom of schizophrenia. So my advice is that people should seek consultation, try to find out what's going on, what is the cause of the hallucinations. You know, there are other brain diseases that might also play a role in causing hallucinations, so someone should really seek medical attention. If they're hearing voices and the voices are not having any impact on their functioning, that's different from someone in whom the voices are really very disturbing. And what you described in this lay press article was that, you know, people are trying to make the voices less disturbing and more acceptable. If that's possible, and if the person is functioning well, you know, then they may not need treatment. But it's really a question of what is happening in that overall person's life and their ability to function. And I think that's where consultation with a mental health professional can be important. But there also may be situations where coming to terms with the voices, accepting them, if they're not having an impact on the person's ability to function, might be feasible. But it's a very complicated area, and my advice to people is, you know, don't go it alone on this. Yeah. There are groups that are not always well informed. There are groups that are not basing their opinions on evidence. As physicians, you know, we like to see evidence. I also would strongly recommend that people take advantage of information that's available on the Internet from the National Institute of Mental Health, for example, or the National Alliance on Mental Illness. These are organizations that really keep tabs on the developments in research and science, and so I think it's important. There's a lot of debate. Many people are sort of mistrustful of psychiatry. They're concerned that they won't be treated properly. Obviously, being a psychiatrist, I don't think that's true. I think they should give it a chance and get a consultation.
I think that seems like a great place for us to leave it. So, John, thank you so much.
My pleasure. Good to talk to you.
So my guest has been Dr. John Kane. He's the co-director of the Institute of Behavioral Science at the Feinstein Institutes for Medical Research at Northwell Health. He's also the immediate past chairman of the Department of Psychiatry at Northwell Health. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.